transition quickly over to Dr. Alonzo Plough and introduce him real quickly. Apologies for running a little bit over time. But Dr. Alonzo Plough is joined the Robert Wood Johnson Foundation as Chief Science Officer and Vice President of Research, Evaluation, Learning. In January 2014, he's responsible for aligning all of the foundation's work with the best evidence from research and practice and incorporating program evaluations into organizational learning. Dr. Plough, I'll take it away.
Great, thank you. You're going to run my slides from there? Yes.
Yes.
Excellent. Okay, great. Well, good morning, everybody. I'm going to talk a little bit. I was asked to talk a little bit about social determinants of health, and just quickly in my background, a kind of an academic, very quantitatively trained epidemiologist, finding my way into public health practice, running health departments in Boston, Seattle, and Los Angeles, and increasingly always thinking about the integration of research and practice. So my practice was public health practice. So in many of my systems, we also had a clinical side as well with our FQAC network. So I'm going to approach this from that kind of mindset. I'm a relatively short-term philanthropist, so think of me with that other part of my career, though we focus a lot on these issues at the foundation. So I really want to present, next slide, please. I want to really try to present the social determinants of health, and particularly relating it to inequities. So again, what is it about the social determinants of health that create health inequities that we need to address at a population level? The social context for health inequities in the US, and then addressing inequity by what I would call a socially determinant informed practice. And again, all of your practices sit in communities. Those communities have characteristics. Those characteristics, the place, the history of those places, and those population dynamics are reflected in who comes into your offices. And the dynamics of understanding relationship between what you see clinically and what happens at a population level. I think the future of improving health outcomes in the United States is more dynamic integration, understanding of those contexts. Next slides. So approaching disparities at the foundation, and I think the field looking at social determinants is looking upstream. Hit the slide again. And we know that these disparities are driven by inequities. Hit the slide again, please. We know inequities are driven by discrimination, particularly of people of community of color, and hit the slide again. And the discrimination is based on bias. And again, these factors have clearly demonstrated outcomes that relate to health. Next, click the slide again. So if you're going to deal with health disparities and social determinants, we need to work upstream. Next punch of the slides. So again, as in the social determinants of health world, and the way we are thinking about this at the foundation and really across the country, as we're trying to integrate social determinants into improving healthcare outcomes at a population level. What happens at the healthcare interface is really influenced by these upstream factors. How do you address those with confronting and dealing with the impacts of racism, explicit advocacy, policy changes and practice changes across institutions that really will help to make our healthcare interventions actually more successful. Next slide. Just a little bit about Robert Wood Johnson Foundation. I think you all know that who we are, New Jersey-based national foundation, largest foundation focused exclusively on health. And we are really working on particularly on implementing this kind of thinking through our culture of health. What does it mean for us across sectors to think about our collective role in a fair and just society, how that influences health equity, meaning the ability of populations to have the best health outcomes possible, and not be limited by the factors on the previous slide, which helps us as a nation get to optimal health outcomes. Next slide. I'm going to run through a series of slides that really talk about the lessons we learned from COVID-19. So I think everyone is aware, I'm sure all the people in this call are aware of these issues, the issues of racism, discrimination, bias, all of that. You see that in your practices. We have seen this, certainly the events of 2020. And I speak about that as the confluence of the pandemic of COVID-19 and the endemic of racism converge to give us some fairly stark population health outcomes. What's in red here are from CDC. These are particularly underlying medical risk factors that are more prevalent in African-American populations. Next slide. So those underlying conditions, and I think the reporting on this was quite confusing. Those clinical conditions are related to a variety of the inequity, lack of access, other things I mentioned on the previous slide. But other conditions, I mean, COVID was another test case to show that the ability to protect oneself against the risk of COVID-19 was based in a variety of conditions. Did you have a life where you were able to wash your hands frequently? Do you have a job where you're coming into close contact people who are sick and without adequate protection? That's sort of the nursing home staff issue. All of these kind of protective factors are contextual based. And again, we see differential health outcomes and COVID based on differences and inequities in these underlying conditions. Next slide. And again, this slide just shows what that meant in terms of disparities due to inequity. These are the COVID-19 hospitalization and death rates by race, ethnicity, and you can see, particularly in the highlighted red, the hospitalization rates extremely high in indigenous populations, Black and Latino, and again on the Black and African American, 2.1 times higher. Again, these disparities are based in these inequities, and the social determinants are ways of trying to understand these conditions of place that influence these inequities. Next slide. I have our global program at the foundation, so I always show a global contextual slide that shows we do invest the most of any of the comparable countries in the world in healthcare, but we do not get the comparable outcomes in terms of life expectancy at birth. So we're down with Turkey. We're with Turkey and Poland. But I think, as a nation, we aspire to trying to understand how we can improve this. And I think the equity, social determinants, connecting care to community, and that sort of dynamic is really important part of that. Next slide. That's just to emphasize the disparity. Next slide. So again, disparities in equity. Whites have the highest rate of known, meaning discovered, diagnosed, and being treated heart disease. 11.5%, and you can see the declining percentages in other ethnic groups. Next slide. But the inequity shows that Blacks die at a much higher rate from heart disease. That's the disparity inequity issue again. Black, not Hispanic, Hispanic, those show those age-adjusted death rates. So again, the inequity. Next slide. Why inequity versus disparity? Another cut at this around social determinants. Income inequality is really important as a social determinant, and you can see the comparison between family income as a percent of poverty and the burden of chronic disease. All data points show that this is not a biological issue; it is a social determinant and a contextual issue. Next slide, please. Again, and it's very interesting that a lot of what is happening in the current administration, a lot of the inequity in terms of income inequality is really key. And then when you're talking about social determinants, income inequality, and you see that in the chart here, really very widely across racial and ethnic groups, and understand the impact of income inequality on health outcomes on a community level becomes critical in understanding a social determinants approach. Next slide, please. So what do you do? I know working with a lot of different audiences, you know, the last thing I heard when I was talking about this at a meeting at NAM is addressing social determinants like boiling the ocean. I would reject that assumption. There is a great evidence base about what to do, and particularly an imperative to begin to think about across the continuum of practice, social determinants, and policy that we begin to work upstream in innovative ways. And there's elements of this all around the country, and I'm going to touch on some of that. Next slide. This, and click this a couple of times. One, two, one more. Okay, this was Tom, go back, one too many. I would have shared my own screen, but I have had mixed success in conferences on my own screen sharing. I will admit that right now. So I mean, here's the health impact pyramid, from Frieden and CDC's approach. What is driving population health? I think this what I don't like about the pyramid is it maybe shows that these things should be connected, but I think it's really important when you're talking about social determinants and you're talking about the drivers of population health, this base of the pyramid, between particularly changing the context that allow individuals' default decisions to be healthier: food environments, primary care access, transportation, playground, jobs, education. These are the social determinants. And the importance of focusing on them is they have this demonstrated large impact on improving population level health. Next slide, please. This is the south side of Chicago, and I'm going to stay with housing as an example of social determinants in community context as important for thinking about social determinants. 1/4 of all Americans live in neighborhoods that really make it hard to be healthy. This is, you can see a neighborhood that doesn't have any of the kind of characteristics of walkability, open space, good housing that would lead to good health. Next slide. And we do a lot of this. I'm sure many of you have seen this. You can look at any area of the country, particularly any urban area. And I'm going to be moving in the latter slides, which I think is really important to what you're going to be doing in your practice-based research, understanding within small geographies, large variation in life expectancy, understanding where your practice, where you are situated in these local geographies, says a lot about the interaction between social determinants and possibilities of improving healthcare and the clinic. This is DC, but we could do this in any other city. I live most of the time in Los Angeles, and you can drive 7 miles from Santa Monica east, and the neighborhoods have lost double-digit life expectancy years just in that. Well, relatively short by miles, but given LA, long time, 5-mile drive. Next slide. I stuck with housing because there's so much research on the health implications of housing. I'm just listing them all here of substandard housing, asthma triggers, behavioral health, all of these kinds of things. A tremendous evidence about that. On the elderly, that's a lot of that is housing and social isolation. But again, a well-researched area, which is why a lot of innovation around connecting population health, clinical care, and social determinants is around this issue of housing. Next slide, please. I'm going to go through a series of maps that are again on the geography of risk. The context of social determinants, and these are national maps. And if I was a better sort of geographic epidemiology, I would have run these things for New Jersey, but I will leave that to some of my colleagues at Rutgers, because all of these small area analytic tools can be done on a small area analysis that would support your practice. But what you'll see in this series of slides, that place, in this case, the red part of this, which is the southeast, the life expectancy at birth is diminished where poverty and marginality are the highest. Next slide, please. You can also see the same thing with income inequality, not just in the Southeast, but you can also see it in pockets around the country. Very important to look at that at a small area geography within your practice areas. This says a lot about what is going to be coming through your doors, and some of the uh, implications of those kind of social determinants to improving care outcomes. Next slide, please. Obesity, same kinds of things. These are all co-occurring contextual driven risk factors, really driven by context, more so than race. Um, Next slide, please. Heart disease. I think the story is about around this is pretty clear. And again, this can be looked at in your own small area analyses in New Jersey. Next slide, please. And then again, it was predictable that you would see the same kind of thing in COVID. People ask what's happening with the white areas. Those are sparsely populated geographies where it's just hard to do this kind of case counting, given the way this was done for the COVID cases. Next slide, please. A couple of different things for researchers who want to connect place and clinical care in this social determinants continuum are these tools. This is one of them. This is the multidimensional index of deep dissatisfaction. This comes from the University of Michigan. You can do small area analysis on this one. The social vulnerability index that comes out of CDC is another good small area tool that kind of tells you the social context and conditions that are influencing life course and life expectancy in the places that you practice. Again, kind of connecting this place-based data with some of the other data sets that have been talked about previously are powerful ways I think, to do this kind of social determinants-oriented practice-based research. Next slide, please. I put this on. Obviously, New Jersey is not a place that had a concentration of slavery like the Southeast, but we've found in a lot of other studies, on small area studies, if you are in a neighborhood, our patients are coming out of a neighborhood that had been redlined, that it had a highway go through and segregate the community. Those historical impacts continue to have well-being implications up to the present. And I just, a lot of analysis and work on trying to understand those continuation of those sort of historical pressures on communities. Very important to understand that as well. Next slide, please. So what can we do about the determinants of health? I mean, the answer is there are many things we can do about it. And I think the imperative around population health is a dynamic connection between a care and community around this nexus of social determinants. I mean, again, it's encouraging that increasingly electronic records are being able to note this. And I think so. I think these connections are beginning to happen. I mean, this talk is just to kind of emphasize the importance this can play for the kinds of research networks and partnerships you're developing. Next slide, please. I'm going to just really go through the study that has been studied the most about the impact of place on health, called Moving to Opportunity. Next slide. And if you Google this, you will find all of the social science analysis from all of the disciplines that you would ever want to see, trying to understand this big national experiment during the time period to really try to understand one important aspect of the relationship of place on health, and experimental group, a couple of different controls, again, very well studied to try to understand, well, if you change the conditions people are living, what happens to their health outcomes? Next slide, please. And MTO showed over the course of a number of years, improvements in mental health of parents and sons who moved from low poverty areas to other neighborhoods. Lower, you can see after 10 to 15 years in this longitudinal study, these kind of changes. And after 15 years, young children had lower hospital spending. Lots of analysis, lots of variation, lots of differences. Still, we're trying to understand about MTO, but certainly it really shows the implications of place and health outcome very powerfully. Next slide, please. What can you do? This is just an example of a community partnership in a neighborhood in Atlanta that actually included a number of healthcare systems as well as other partners that took a old style public housing project in Eastlake that had all of the terrible indicators that you would think of, both poor housing, bad educational outcomes in that community. Next slide, please. Through this community collaborative effort to reconceptualize place and housing for this community. The first point I want to make is all of the residents of the previous community have places in this one. Changing this kind of structure, reductions in crime, violent crime, up employment, student in performance. That's a relationship of housing to social determinants and the nature of these kinds of multi-sectoral interventions. Next slide. I want, again, health systems, healthcare providers have been very important in the kind of anchor organization, community partnerships around this connectivity between social determinants, housing, health. I picked on housing again because so much of the innovation coming from the healthcare side has been around the role of hospitals, healthcare organizations, insurers, really beginning to work collaboratively around housing because of its such tight nexus between problems in housing and corollary problems in health status. So again, a lot of interesting and good work already happening around this nexus. Next slide, please. This is a model, like all models. Again, trying to show this Oasis model from a recent study. Just trying to lay out the social determinants as it really relates to the interface with clinical practice. You can see it at the top. The imperative to identify unmet social needs, address those unmet social needs, improve outcomes. That's the big kind of theory of change piece there. But as you work from left to right, again, trying to understand, screen for SDOHs. It's as our medical records are better able to do this, identifying the needs, but also being able to have referral networks. The model that, at least in the program, we funded Health Leads that Kaiser uses a lot, but there are a lot of these newer models that and approaches that allow this particular connection to be made. And again, the logic model that these researchers laid out, the assumptions of increased connection to resources, decrease unmet need, improvements in outcomes, and improvements in clinical outcomes. Their research connected these green and blue arrows around supported by data and needing further investigation. I think that's a pretty fair interpretation. But this is, again, to kind of summarize what I've been saying, this is what it would kind of look like to incorporate those various approaches to integrating a social determinant-based approach to practice. Next slide. So I'll end where I began. All of us who are doing work in health and public health have got to operate within this broader upstream environment of disparities that are based in inequities, understand the causes of the causes, as we epidemiologists talk about it, racism, bias, and address it on a policy front through community collaborative partnerships. Lots of work and actually models of community engaged participatory research, which I would also encourage your practice-based models to use, and they've been used very successfully in other kind of clinical community partnership research models, and increasingly, I think, bring kind of community voice and experience to the broader range of research and evidence building. I think that's the end. Great.
Great, thank you so much. I really appreciated your emphasis on the importance of community-based research within practice-based research and making sure we engage with the community, and also highlighting of the geographic differences that interact with social determinants of health, because I think that's really part of our mission here is to focus our work on our state and making sure that we can hone in on the differences between our townships, our communities, our counties, etc. So thank you so much for your time. I know that we are running a little over already, and you're on a tight schedule yourself. So if you're able to stay for a question, I welcome it. But I can also,
question or two, if there are, sure,
if
absolutely.
there are any questions, feel free to ask them. Otherwise, we can let you run. Okay, I think that we can just let you off the hook for now, but thank you again. It was a pleasure having you.
Thank you. Great. Bye.
Okay.